Hello, and welcome to Chapter 4. Today we will be talking about pain. As we all know, pain is unpleasant, and as we've all may have experienced before in our personal lives, that pain comes from different sources. This can be from muscle spasms or surgery, it could be from burns, it could be from inflammation or an infection in an area, ischemia, which is lack of oxygen to tissues. It can come from tissue necrosis. It can also come from stretching of tissue, tendons, joints, and ligaments. Regardless of the source of pain, everybody has experienced this before. But the thing about pain is that pain is actually very complex. Just because we experience these different sources of pain does not mean that everybody rates their pain the same. So it's complex in that it is subjective. A lot of times we have to go with the individual's personal pain scale. So if a person is alert and oriented, they could tell me about how their pain is, the quality, how bad it hurts. I cannot assume that the next person would rate their pain the same way as the first individual. So, pain is a subjective experience, and we normally use scales, and we have to, and actually are mandated to go by what the individual states their pain is. So, one individual's pain scale of 3 could be another individual's pain scale of 8, and vice versa. Regardless, we cannot assume that that person is not in pain, or we cannot assume that they're in so much pain. And it drives how we treat the pain overall. So, when we discuss pain, we are mandated to go by what that individual says. So, again, it is a complex concept simply because we don't necessarily have anything that proves what pain is. We do have a theory, and there are several theories to pain, but there's one specifically that we'll talk about. But the issue with it is that this is a theory. It's not necessarily the truth, but it is widely accepted amongst our healthcare profession. So we'll talk a little bit about what that theory is later. The other thing about pain that I want to point out is that it's actually the body's way of letting us know that something is wrong. It is a defense mechanism, and it also serves as a warning. Pain is not a common experience. So when we do suddenly feel pain in different areas of our body or chronically all over our body, we know that something is wrong and that it does need to be addressed. The next thing I want to talk about is the different types of pain. First, we'll talk about these two separate categories. We have somatic pain and we have visceral pain. Anytime we talk about somatic pain, that's either from the skin, bone muscles, and it can be conducted by sensory fibers. Again, when I think somatic, I think sensory S and S, somatic. When we talk about visceral pain, this pain actually originates within our internal organs. And normally, when we feel pain, it is conducted by sympathetic fibers. So that has a lot to do with our sympathetic nervous system. And this visceral pain can be acute or chronic. An example I like to point out with this is gallbladder pain. This is a type of visceral pain because it originates in the organs. A lot of times we suddenly develop gallbladder issues and it's associated with nausea and vomiting. But another telltale sign is pain in that region of our bodies. So this is a type of acute visceral pain. And normally, if we start experiencing a lot of pain in our gallbladder, we have to get a surgery to get that removed because it's infectious or inflamed. So, visceral pain would be considered gallbladder pain. Somatic pain can be simply a cut on the top of our skin, um, and it can go through to the bone and the muscle. Moving further into our discussion of pain, it's important to know that there are two types of pain, and I want you to familiarize yourself with this chart because it provides a very good comparison of what acute pain looks like versus chronic pain. So you can have acute pain. Normally, acute pain is sudden, it's fast, and generally it's localized. You can have acute pain from different types of injuries. Here it lists mechanical and thermal, but I like to also point out it can be, when we talk about mechanical, that's actually a physical type of injury. And there is a pathway that we look at when it comes to how pain is sensed through the bodies. There are fibers called fast A, delta myelinated fibers. And normally that's how our brain senses the trigger and it tells us that, hey, we do have some sort of acute pain process. Again, it is a short term sudden pain. Normally, we do see vital sign increases such as blood pressure, pulse, or heart rate will increase. Sometimes this acute pain can be associated with nausea, vomiting. Sometimes the skin can be cool and moist. A lot of times when we have this acute pain, it is associated with anxiety. And ideally, once we experience this acute pain, we have to identify the primary cause and treat what that primary cause is. So, in the last example, I did talk about gallbladder disease, so or acute gallbladder infection. So the treatment would be to hopefully treat the pain, but eventually that will have to be removed simply because that's the primary cause of pain. Once that organ is removed, then generally the pain subsides after surgical site heals. The next one we'll talk about is chronic pain, and normally this is slow and diffuse. And when we talk about diffuse, this means that it slides all over the body, so we feel it everywhere. A type of chronic pain can be those that are terminally ill with cancer or may have an immunological disorder or immunocompromise. So this pain is prolonged and it continues to exist. A lot of times when we have chronic pain, the stimulus is pre-existing, so it can stream from an acute pain, but eventually it becomes more chronic and it keeps existing and it keeps presenting itself. A lot of times we characterize chronic pain by exacerbations and remissions, which means that when we exacerbate, it's present and it's currently happening, whereas in remission, that pain has subsided. But regardless, this pain comes and goes. The pathway is that you have slow unmyelinated C fibers. So, um, with the response, a lot of times it is a long term and disabling disease. This is different from acute pain where it's sudden and short term. Chronic pain is long term, and again, it is characterized by those remissions and exacerbations. You have all kinds of issues that can ensue from that, such as fatigue, depression, irritability. A lot of times, we don't necessarily see nausea and vomiting with chronic pain because the person has dealt with it so long that their body is just used to the chronic stimulus of pain. So you don't necessarily see a lot of nausea and vomiting, but that does not mean that it can't happen. This is just primary response. So again, you'll see individuals that are depressed due to the long-term effects of chronic pain, fatigue, irritability. A lot of times, you do see loss of hope and anger as a result of their pain because it feels like they can never get rid of it. And understandably so, if you're suffering with pain, you don't want to be in pain. That's not normal, and it can wear on the mind. As far as treatment, it is difficult to treat chronic pain, and a lot of times we do see individuals develop a tolerance or a pain tolerance to different medications. This is why we have to do something called a multimodal approach. So we don't just give the same pain medicine all the time. Sometimes we have to rotate what types of pain medications we give. An example of this would be sickle cell. Even though the pain occurs acutely, this is something that individuals with sickle cell they experience long term. So when they have a pain crisis, we have to figure out what works best for them. So a lot of times we may treat with dilaudid or maybe even a PCA pump of morphine or dilaudid, depending on how severe that pain is. We may have to go back in with a supplemental medication or ancillary medication. Um, Sometimes we have to give an antidepressant as well. But the thing is that they're constantly going to be in pain, and this pain is in remission or it can exacerbate, and we have to treat the acute symptoms in that. So, chronic pain, again, is very difficult to treat effectively, but it can be managed. It may not be to a point where we can get complete pain free or get them completely pain free, but we try to get them as painless as possible. So we have different pain pathways, and this is part of our gate control theory, which I'll talk about in a little bit. But the first part of learning about the gate control theory is knowing that we do have pain receptors, otherwise known as nociceptors. These are nerve endings that are present in most tissues of the body. And again, it can be stimulated by chemical means, thermal means, physical means, or mechanical. So when we talk about stimulation, these are the triggers that cause pain to ensue, or it's what we feel with our pain receptors that tells us, hey, there's something going on and I have potentially hurt myself. So when we talk about thermal triggers, that's like if you're referring to different extremes of heat, cold, sometimes that could trigger a pain response. Chemicals such as acids or very strong bases can be produced in the body, or you could touch it and it'll cause an inflammation response. With that inflammation response, you have different compounds that are stimulated in the body, such as bradykinin, histamines, and prostaglandins. And again, these are all associated with the inflammatory response. Then we have mechanical or physical means. And again, this is pressure or actually cutting. This is where we have direct injury to that area of the body where those tissues reside. So nociceptors receive these signals from all of these areas, and it can tell us that there is something wrong with our body. So here is our pain pathway, and I really like this chart because it tells you exactly how pain is transmitted through the body. Now, this is one of our theories, so this is just kind of how we think pain travels through the body and tells us in our brain that something is wrong. So you have the stimulus in this chart. You see that the stimulus is a nail. That nail triggers the nerve endings, such as the nociceptor or our pain receptor. Eventually it goes through something called the peripheral nerve. So this is from the outside of the brain, of the nervous system. This is the outside pathways. You have your central nerves and you have your peripheral nerves. A lot of times when we get injured, it's from our peripheral nerves. And so this is in the area that's not quite yet made it to our central nervous system where our brain and our spinal cord are. So you're still on the outside here. So you have peripheral nerves, and it's going through the afferent pain fiber. And when I think afferent, that word afferent, I think two, it's traveling towards something. Afferent is a fiber that travels towards. You have your dorsal ganglion and dorsal root that stimulus continues to go through. And then you have a synapse. The synapse is transmitting a signal from the peripheral nervous system to now the spinal cord and eventually the brain. So this is the point where we see transition from the peripheral nervous system to the central nervous system where our brain resides. So this is where the synapse happens. And then it goes through the lateral spinal thalamic tract. And again, this pain is traveling through this area because eventually it'll need to get to the thalamus, which will tell us that our sensory area, something's wrong with our sensory areas. When we talk about sensory, again, that's that stimulus that has started this whole process. So again, pain is traveling, or the signal of pain is traveling now through the central nervous system. Then we have the reticular formation in the pons and medulla. This is where our brain finally realizes, hey, something has happened. We are hurt. Eventually, it travels to the thalamus where the sensory is relayed to the brain. And really, when we get to the reticular formation, this is where it starts to travel through the pain. And it's also important to note that this signal is traveling to several parts of the brain. One of them is the sensory relay center. It tells us how bad it is. The somatosensory in the parietal lobe tells us where it's happening, so we know that we've been hurt. We feel the stimulus. We know exactly where it hurts. When it gets to the hypothalamus, this is where we feel stress, and this is a lot of times where we start seeing our vital sign changes. So you'll see higher blood pressures, higher pulse, because the stress response or the fight or flight response, sympathetic nervous system, has been activated. So we do see a stress response. And then finally, it goes to the limbic system within the brain, and that's where we have our emotional response. And a lot of times, this is where we start crying. So this is kind of how pain travels through the body and what we believe is the most correct when it comes to how pain is sensed in the body. So that brings me to the gate control theory. The previous slide was talking about how pain is sensed from our peripheral or from wherever the stimulus has occurred all the way to the brain where it tells us, ow, we're hurting and something is wrong. So now we'll talk about the theory that I mentioned earlier in this lecture, where this is just a theory. This is something where we believe it's the most correct, or we generally agree that this is what's going on when it comes to pain. So, what the gate control theory says is that you have control systems or gates that are built into your pain pathways, as mentioned before, and it can modify pain stimuli and conduction and the transmission from the periphery to the spinal cord and brain. Again, we have to have that stimulus from the peripheral that tells us in our brain or central nervous system that something is going on. So when we talk about gait and modification, eventually the body knows that we're hurt, but we're going to try and stop that sensory process because we don't want to feel pain prolonged. So when the gates are opened, pain impulses are transmitted from the periphery to the brain. So that's notated by chart A. And this is on the top on the right here, where we have that painful stimulus. The nociceptor is transmitting the pain. And again, you have your peripheral nerve delta A fibers, which are the quick ones, or your C fibers, which are the slow ones. A for acute, C for chronic. But it travels through to the synapse, and substance P is a molecule that helps with the pain response, and it kind of tells us what the pain response is. Once we get into the spinal cord, that spinal cord is transmitting the pain stimulus to the brain. Then you have the reticular activation sequence that happens, and then you have pain that is perceived. So this is when the gates are open. The stimulus occurs and it travels through the peripheral, through the central nervous system, all the way to the brain. Whereas when we close the gates, you have that peripheral stimulus, but what occurs is that we have these impulses that are kind of shut off. So that has a lot to do with the substance P. So note that when we have the gates open, substance P is relapsed, is open, or it's released. Whereas in the gate control theory, when it's closed, substance P is not released, as notated on this chart. On the bottom here, substance P won't release when we're trying to close this gate. So if substance P is not released, the gate is now closed because we do not have the substance or the particles that help transmit pain. So eventually they shut that gate off, or eventually the passage of pain is modified and or reduced, and we no longer get that signal transmitted from the spinal cord all the way to the brain. So it shuts off kind of right here in the spinal cord. And this makes a lot of sense because once we have pain, we'll experience it, but eventually that pain kind of dwindles down. It'll stop being, as I should say, aggressive. We believe that that's because our body recognizes pain, but it knows that it does not want to be in pain very long. So the gates will close from the peripheral nervous system to the central nervous system with conduction of those stimuli. Okay, so now we'll talk about the pain assessment and characteristics of pain that we should look for. It's important to know that as a clinician or healthcare provider, that pain can tell us a lot of information. So we should be doing a very thorough pain assessment every chance we get upon meeting our patients and throughout our time with our patients, because pain can happen at any point in time. So you can use verbal cues. They can say that they're hurting, or you can use nonverbal cues and just kind of see if they are having any vital sign changes, or grimacing, they're clenching or guarding. This can tell us that there's some sort of pain process going on. If the individual is not alert and oriented and cannot tell us what their pain scale is, it's important to still assess pain using our various pain methods, So we have the Wong-Baker-Faces scale. We have the pain ad for dementia patients. We have CPOT for those that are sedated and intubated in the ICU. There are different ways that you can assess pain. So there's no reason why a patient should not be assessed for pain at any point during your shift. So with that being said, you always want to assess the location of the pain, where it is, and it can be all over or generalized, or it can be localized to one area. It just depends on what's going on. You want to make sure that they tell you the quality. Is it moderate, unbearable? Is it aching, discomfort, burning, sharp, throbbing? Is it diffuse, widespread, cramping? You want to make sure that they describe their pain as much as possible. You also want to talk about the timing of the pain. So, is it exacerbated before meals, after meals? Is it more so when there is pressure applied to that site, or is it where they're not doing anything at all and it's just painful? So you want to ask what may trigger the pain or the timing of the pain. um, you may also want to look at the nonverbal cues as well. Again, you see guarding or facial grimacing. Sometimes you'll have physiological changes such as hypertension or high blood pressures, tachycardia or high heart rate. You'll see diaphoresis or sweating, nausea, vomiting, dizziness, fainting. All of these can be physiological changes of impending pain or severe pain. Um, Even anxiety and fear. Sometimes individuals have a more increased anxiety due to the fact that they're having these acute pain processes. So that would be something to assess as well. You always want to look at the patient's perspective, and it's exactly what the patient says that it is. Now, with our infant population, those that cannot talk, a lot of times you can also see facial expressions with those babies as well. You can see tachycardia or increased blood pressure, and that can tell us that they're in pain. And another thing about children is that the developmental stages matter. I just talked about how infants, we normally look at facial expression, tachycardia, blood pressure to let us know if they're in pain or not. Well, if they get into the children stage, sometimes the children don't know how to express themselves. This is why we use Wong Baker, so they could tell us how they feel by the picture. Um, they oftentimes have difficulty describing their pain, so pictures work very well for them. And then if you have older children, even into adolescence, a lot of times they withdraw or lack communication simply because they don't want to be in pain and they don't feel that it's fair, so they'll withdraw and not necessarily address it at all. So you want to be mindful of these different types of pain with these populations. So this is a really good chart because it tells you about all the different types of pain that can be perceived by others. So we talked about two earlier in this lecture. We talked about somatic pain, and we also talked about visceral pain. But I also want to go into these different other types of pain. So you have referred pain, which is a localized area of pain. And then you have individuals that may have had an amputation of a limb. They can still feel pain in those areas. So we call that phantom pain. And again, it's normally where the limb that was previously there, they perceive pain to be there. And a lot of times we think that this is because the brain doesn't necessarily know that the limb is missing, but it'll still transmit those pain signals to the brain. So phantom pain is real, and you still have to treat it as such. Um, Acute pain, we talked about that. That is acute onset, or it's short and sudden, and most times it's severe. But it normally resolves once we get rid of the etiology or the start of the pain. Again, it can be localized or generalized, and it does normally go with the physiological responses such as high blood pressure, high heart rate, sweating, even increased respiratory rate. You can see vomiting and nausea. And again, we do have an emotional response and high anxiety levels. Chronic pain, we talked about this one as well, and that is, as a reminder, is over time, and normally it's characterized by remissions and exacerbations. The individual has suffered with this for a long time. A lot of times we see this pain in those that are terminally ill, maybe immunocompromised, or maybe have cancer. But it's a generalized pain, so it's not just one place, it's all over. Um, It can be debilitating and can cause depression simply because the individual cannot seem to get rid of the pain. A lot of times, these individuals are depressed or irritable as well. You also may see some sleep disturbances with individuals with chronic pain, which can also lead to irritability and depression simply because sleep hygiene has been affected. It can also lead to weight gain or loss. When we talk about central pain, this is pain that is caused by the brain or the spinal cord. So, if we have a traumatic brain injury, even like a hemorrhage, or even if it's a stroke, sometimes it can result from direct injury to the brain, causing pain functionality. So, again, central pain is normally referred to pain that is experienced in the spinal cord, in the brain, and it can be chronic after such of an injury. So it's important to look out for that. Neuropathic pain, this is a type of peripheral nerve pain, and it's most likely in an individual that has diabetes mellitus. In fact, this is one of the signs and symptoms that we have for individuals that have diabetes. And neuropathic pain can be as simple as tingling or burning to a severe shooting pain. And it's important to know that the nerves can be excitable or hyperexcitable. So that means that if there is some sort of pain stimulus, there may be a more exacerbated pain simply because of the condition of neuropathy. But sometimes these individuals can also feel numbness. So neuropathic pain can get so bad where they're numb and they don't necessarily feel the pain anymore. This is why it's important for those that have diabetes to constantly inspect their extremities, their legs, their feet, because with this neuropathy, sometimes they don't feel the pain at all, and they may have injured their foot, and this is how we have ulcers that form on the feet. Okay, so next we'll talk about ischemic pain, and this is a sudden loss of blood flow to an organ or tissues. And again, when we talk about ischemic pain, this is normally where we have no oxygenation to those tissues, so we do not have any perfusion. A lot of times, this decreased oxygenation to the blood results in hypoxia, and it can produce pain to that organ or extremity that is not being perfused. And then we have cancer-related pain. And again, this can be kind of associated with chronic pain, but it is associated with the treatment of disease. So cancer, a lot of times they're going through radiological therapies. They're going through these chemical treatments, and that can cause pain on the inside. And sometimes this pain can be the result of a coexisting disease unrelated to the cancer. So, cancer-related pain is simply something that is associated with treatment, but sometimes the pain can develop that is not a direct result of the cancer. And then you have intractable pain, and this is pain that cannot be controlled by medication. A lot of times you see individuals that that have intractable pain that are also in chronic pain. So that this pain cannot be controlled. Normally, there's some sort of surgical intervention that is required. There are individuals that have like certain joint pains, and no matter how much they treat with anti-inflammatories, opioids, opiates, even ancillary medications such as Lyrica or even gabapentin, this pain does not go away. So sometimes they have to actually remove that extremity in order to get rid of the pain overall. So this would be a form of intractable pain that needs to be addressed. Here's a reminder chart. This chart is really, really nice in giving you the details of acute pain versus chronic pain. So I would familiarize myself with these similarities and or differences, and just make sure that you're familiar with the differences between acute pain versus chronic pain. So let's talk about pain treatment. A lot of times when we have pain, it does need to be addressed. So as a clinician, you have to know what's available to you to treat pain. So we have mild pain, moderate pain, and severe pain. A lot of times when we deal with mild pain, that can be treated with aspirin, or you can treat with acetaminophen or NSAIDs. Um, it's normally an anti-inflammatory. Um, and it's normally something that can help reduce pain quickly. And a lot of times we give these medications by mouth or PO. It's important to know that for mild pain, you can still have adverse effects with these medications, such as nausea, ulcers, bleeding, and even allergies can be an issue. But if that's not the case, then this would probably be the best first line of treatment, because ideally we want to treat with the least amount of opiates as possible. So if you can use any of these first three and get the pain under control, that's what you want to do first. But unfortunately, sometimes people's pain is not able to be managed with just Tylenol or NSAIDs such as ibuprofen or naproxen. You have to go down to something a little bit stronger. So we do have opiates that are involved. So you have codeine, oxycodone, Percocet, Vicodin, and these are narcotics. These are things that need to be counted and are very well kept up with, because people can develop a addiction to these drugs. But the actions that they do act on the central nervous system. So when we talk about the central nervous system, that is the brain and that is the spinal cord, and it does affect the perception of pain. So although we have a stimulus that is causing us pain, whether acute or chronic, this helps work on the areas in the central nervous system and helps hopefully dampen that perception of pain. So these are really good tools to use for moderate pain. Um, One thing to remember about narcotics, though, is that we do have to make sure we do a thorough assessment of our patient. These medications are contraindicated in those that have low respiratory rate, low oxygenation. And sometimes you have to just make sure they're not overly sedated when you're giving these. A lot of times you may see these narcotics combined with a mild pain, such as acetaminophen. So one of those medications is Percocet. That's actually oxycodone and acetaminophen combined, and we call that Percocet. So you get both modes of pain in the same medication. Again, these medications are normally given PO by mouth, and again, we do have to make sure we assess and make sure that the patient can get these medications. For severe pain, you have even stronger opiates. So this would be hydromorphone, morphine, Demerol, methadone, meperidine, oxy. These also act on the central nervous system. So this is through the spinal cord and the brain, and it causes a euphoria and sedative effect. Again, you can get addicted with high doses, and these also depress respirations. A lot of times we have to worry about constipation for when we give these medications, because they do slow the GI tract down. But we can also see individuals catch a nauseous spell. So if we're giving something this strong, we'll oftentimes pair that with antiemetic to help with the nausea. Again, this is contraindicated in individuals that have low respiration. So I can't give this to somebody that already has a respiration of 8, 10. It's actually kind of contraindicated in that. So why do we have all of these different analgesic drugs? Well, the thing is that we want to practice a stepwise fashion to reduce pain. So again, we try to treat with the least sedative first, and then we go on and so forth, because there is a tolerance that can be developed or addictions can develop. So we try not to predispose our individuals to those means. Sometimes when it gets to the severe pain, we may still have to treat with that, but we also have to increase dose requirements. But it's not accepted practice to do that immediately. We like to treat with mild pain analgesics first before we give them stronger ones. You do have adjunctive therapy to analgesics. A lot of times we'll give anti-anxiety drugs. Again, anxiety is one of the causes of or one of the symptoms of pain, so especially acute pain. So we may even give them an anti-anxiety medication, and what this does is that it may help reduce the drug dosage for the primary analgesic. It also helps to promote rest and relaxation, and we get a better multimodal pain response when we do it this way. So it's very important to know that individuals may need a multimodal approach when it comes to their pain treatment. Next, we'll talk about anesthesia, and you have several types. You have local anesthesia, You have general anesthesia, and then you have spinal anesthesia. So what this does, we'll talk about local anesthesia first. And normally this is injected into the skin or the mucous membranes. So you can have this injected to your oral mucosa. You can have it injected into your skin. And what it does is that it helps block nerve conduction, as we know that when a stimulus occurs to our nerves, that sends our nociceptors, send those messages to our brain. So a local anesthetic helps prevent that portion of our pain receptors. And a lot of times it's a really nice, mild way to give an anesthetic. A lot of times we'll give lidocaine. You may have seen lidocaine patches. We also inject this directly into the skin. And sometimes we may even add epinephrine to this as well. You mostly see this with a tooth extraction or skin lesions. General anesthetics are normally given intravenously or it is given through inhalation. So, general anesthetics are for general surgery where you don't want the individual to know that you're cutting on them or you're having to do some work on their body. So, a lot of times when we do general anesthetics, it's to hopefully help put them asleep and make them less aware of the procedure that's going on. Again, we can give this intravenously or we can give it to them through inhalation. Nitrous oxide is something that we also use in the dental world to hopefully help decrease awareness. General anesthetics generally affect the brain, and you do have a loss of consciousness when you get this. Thiopentosodium is another general anesthetic, and it's given intravenous. But again, the goal is for you to not have any awareness of what's going on. You have relative anesthesia. Normally, we'll give diazepam as an anesthetic, but what happens is that the patient is still awake. Their response is just dampened. So you do see some response with that. Or you may even see a combination of these medications given. When we talk about spinal anesthetic, we normally see this with epidural. So this is where pain medication is injected directly into the spine. You can inject this into the epidural space, normally around the lower spinal cord. And this is to help with, most importantly, labor and delivery. Or even if you're having surgery on the lower part of your body, such as a C-section, you want to get a spinal anesthesia. But it blocks nerve conduction below the level of injection, so you don't feel anything below that area that they insert that epidural, which is good when it comes to labor and delivery and or lower body surgery. Okay, so these are different types of anesthesias. It's good to familiarize yourself with this chart just to make sure you're aware of what type of anesthetics that are available. Okay, so here is our last slide. We're talking about headaches and treatment. First of all, I want to talk about there are different types of headaches. You have tension headaches, congestion headaches from sinuses and drainage, and you also have migraine headaches. A lot of times when we talk about tension headaches, this is the result of a emotional stress, and it results in muscle spasm and can cause your neck and the muscles in the neck to contract. A lot of times this can be stimulated from just sitting a long time at work or being in the same position or even just being in high stress environments. But the result is that you have an aching that is constant. Normally it's in the occipital area, and sometimes it can last for days or weeks depending on that trigger or that stimulus. The next one we'll talk about is congestion headaches. And this one, again, is associated with the sinuses or nasal congestion. Even eye strain is associated with congestion, but these can be very severe. Normally, these headaches are constant as well, but it's ideally removed once you treat what's going on, whether that's your sinus or taking medication for your sinuses or allergies. A lot of times this will go away once you start doing that. Migraine headaches. These are headaches that happen on one side or the other of the brain. Normally they're unilateral. And these migraine headaches are precipitated by an aura. So a lot of times you'll see like this dim light, or sometimes the individual may see spots or different things in their eyes before the headache ensues. Migraines can be long term and they can last a while. And again, they are normally unilateral on one side of the brain or the other. When we talk about treatment modalities for your different headaches, it's important to know what's available to you. So you have NSAIDs such as aspirin, ibuprofen, naproxen. You have acetaminophen or Tylenol that's available to you. You can even have ergotamine or the derivatives of ergotamine, which you have to take immediately after the onset of the headache. Now, this may worsen nausea, but you can give with an antiemetic to help with that. Caffeine has been known to help with headaches, and even triptans can also help with particularly migraines. So, you may have heard of a medication called sumatriptan or Imitrex or amlodipine exert. These are medications that are specific to migraine headaches. We can also use opiates to treat headaches, but we don't want to get into a habit of treating with opiates because the high risk of getting dependent and addicted to that. So we try to do all the other things first, such as NSAIDs, Tylenol, ergotamine, caffeine, and even triptans before we even consider opiates because we just don't want individuals to get addicted to these medications. So just make sure that you familiarize yourself with the different types of medications you can use to treat headaches and the different types of headaches that we have. Okay, well, that concludes our lecture for today. Thank you for listening. When you look through your notes, just make sure that you go over the questions, make sure you read your materials appropriately, and take good notes. And if you still have any questions or need to reach out, please let me know, and I'll be more than happy to assist you. Thank you.